Hi, it's Dr. Lindner. Let's take a look at some respiratory diseases. So one of them is cancer of the throat. When we talk about cancer of the throat, this is going to be when there's an abnormal accelerated growth of epithelial tissue that lines the larynx. Typically, when someone opens up their mouth, the tongue will look very, very patchy white. The term for white patchiness, they call it leukoplakia. Leukoplakia is white patch in the mouth. Primary cause is going to be smoking. The symptoms are going to be like this chronic hoarseness of the voice, a chronic cough. The individual says they feel like a lump in their throat. They have hemoptysis. Hemoptysis is when the individual coughs, they cough up blood with it. That's hemoptysis. And that'll often be accompanied by something called dysphagia. And dysphagia is the difficulty of swallowing. What do they typically do for something like this? It's either radiation, chemotherapy, or they'll have to remove the larynx. When someone has cancer of the throat, here's the lumen. You'll see the abnormal growth of epithelium, which decreases the size of the lumen. So the individual has difficulty with swallowing, for breathing, for air, for everything to go down in this area. Okay, it feels like they have a lump in their throat. Asthma. If you look on the right-hand side, right, picture says 1,000 words. If you look at the lumen, the bronchial lumen on the right side, this is a non-asthmatic person. You see that the muscles around the bronchial tubes, these are nice and relaxed and allows for the airflow. If you look on the left-hand side, this is where the bronchial tubes tighten and thicken, and the air passages become very inflamed and mucousy and difficult for air to flow through here and become somewhat wheezy. There's often like a whistling, wheezing sound that comes through all that inflammation. And what's happening is you'll see that number one, there's an antigen that enters the airway. Now this right here, this is a mast cell. And here's an antigen. The green little spikes are the antigen, which is the foreign protein. It's going to bind to this mast cell, and mast cells release histamine. Histamines are dilators. They make things swollen and inflamed. You'll see number two, it says the mast cell degranulation and releases mediators like histamine. So right here, number three, you see the mediator effects. There's mucus secretion, there's the vascular leaking of fluids, the airway smooth muscle constriction takes place. So you have a lot of inflammation, a lot of mucus that's accumulating. And you could see down here below, besides the mast cells that are releasing histamine, we have these eosinophils. Eosinophil is a white blood cell. It's a granular site. Basophils, eosinophils, and neutrophils. These are eosinophils, and these are going to these are always increase in number of times of allergy, because they happen to release histamine ACE. Okay, they're trying to combat the amount of histamine that's released by basophils and even mast cells. Okay, so that's a little bit on asthma. Now, bronchitis, that's an inflammatory condition of the bronchi, and that's characterized by swelling, erythema, which means redness of the mucous membranes that line the bronchial tubes. And bronchitis can be either bacterial or viral that can cause it, even smoking. And again, it kind of looks like the lumen with asthma, right? On the right-hand side, this is bronchitis. On the left-hand side, this is a normal bronchi. What are the symptoms? Dyspnea. Dyspnea means difficulty breathing. There's chest pain and back pain. And there could be a productive cough or a non-productive cough. Productive means like that mucus and phlegm causing type of cough. There could be wheezing with that and fever. And typically the medical treatment for that is antibiotics and respiratory therapy. Whenever an antibiotic is taken, you should be taking a probiotic, usually within a 4 to 5 hour window of taking the antibiotic, okay, to try and save some of the microbiome in the gut. Pneumonia, this is an acute infection of the lung tissue and or the bronchi. Typically with pneumonia, there's extreme fatigue, they're tired, there's a fever, there's chest pain, back pain. And when they breathe, if you listen with a stethoscope, there's often the sounds of crackling that's heard through the stethoscope with breathing. They're often very, very tired, and there could be a productive or non-productive cough. They'll often take an x-ray and they can see if there's any accumulation of fluid with pneumonia. Causes of pneumonia are patients generally develop when they're experiencing prolonged periods of lowered resistance. The flu is notorious for bringing on pneumonia if there's not appropriate treatment that's taken. And the types of pneumonia, it could be bacterial like Streptococcus pneumonia or Staphylococcus aureus or Mycoplasma pneumonia. So there's different variations of it. And again, the symptoms are going to be high fever, could be greenish or yellowish type of mucus, a productive cough. Sometimes they hear these rales, these abnormal sounds on inhalation and exhalation with chest pain and back pain. COPD, chronic obstructive pulmonary disease. That's where we get the term cold. He or she has a cold, which is chronic obstructive lung disease. So they're just substituting the L for the P for pulmonary. So the typical COPD is going to be chronic bronchitis or emphysema. Those are the two combination disorders. With chronic bronchitis, this is characterized by inflammation of the mucous membrane lining the internal surface of the bronchi. And the internal surface is going to be red, swollen, and inflamed upon bronchoscopic exam. There's going to be reduced diameter of that lumen airway, which results in dyspnea, difficulty breathing and wheezing. And this could be caused by bacterial or viral infection, could be an allergy or even chemical irritants. And this is typically treated with antibiotics, okay, especially if it's bacterial. Sometimes they'll use steroids like prednisone when it's caused by some sort of chemical irritant like allergies or even smoking. Now, emphysema, this is a disorder of the lungs, and it's characterized by a breakdown of the elastic tissue of the lungs. And there's going to be chronic inflammation of the lungs where the chest appears to be like in this barrel chest type of deformity. The tissue of the lungs produce an enzyme known as elastase, right? Everything that ends in ase is an enzyme. And elastase is designed to break down old elastic tissue in the lungs and allows new elastic tissue to be produced. The new elastic tissue, which is produced by the cells of the lungs, allow the lungs to maintain their natural elasticity, their normal function. Another enzyme known as anti-elastase is produced by the tissues of the lungs, which inhibit the breakdown of elastic tissue in the lung by inhibiting the function of elastase, right? Anti-elastase is going to be against elastase. And some of the chemicals that are contained in tobacco smoke inhibit the function of anti-elastase, resulting in an increase in the activity of elastase, which results in an increase in the breakdown of the elastic tissue. So when that occurs, the elastic tissue in the lung is destroyed. And as the result, the destruction of the elastic tissue in the lung The compliance, which is the effort required to inflate the lung against the resistance of the lungs and the tissues of the thorax of the lungs, it increases. So that's going to result in this hyper-inflated lung and a reduced ability to exhale. And that is really the key characteristic of emphysema. So they get this very muscular, thickened barrel chest type of appearance with a hyperresonant lung on percussion, which is tapping with the finger over the lungs. It's going to sound like a hollow drum. There's labored breathing with it, and increased size of the secondary respiratory muscles because they're working so hard to try and exhale. The therapy is prednisone, right, anti-inflammatory steroid. And since emphysema is always caused by smoking, it's the cessation of smoking along with respiratory therapy. So if you look at the person on the left compared to the person on the right, you can see on the right-hand side, that's what they call that barrel chest deformity, that thickened musculature to try and help to exhale and get the air out. But if they were to percuss over this, it would sound very, very resonant. This is a common appearance with people that are having advanced lung cancer or decreased oxygenation. They'll have this appearance of the nails called clubbing of the nails. And you'll see the thickened cuticle right here, and then the nails really arc down. They call that clubbing of the nails. It's seen with lung issues, lung cancer. It's also seen with people that have severe Crohn's disease also. Okay, let me just see where we are here. Okay, so when we come back, we'll talk about the respiratory. You know what, let's talk about respiratory muscles now, since we were talking about exhalation and emphysema. So the blood supply to the lung, the blood's going to enter the lung through the pulmonary arteries and the bronchial arteries through systemic circulation. And the blood's going to exit the lung by way of the pulmonary veins and the bronchial veins. Now, in pulmonary ventilation, airflow between the atmosphere and the alveoli of the lungs because of this alternating pressure difference created by the contraction and relaxation of respiratory muscles. So we have muscles of inhalation and muscles of exhalation. When the pressure and atmospheric pressure of the gases is greater outside, it forces the air in. When we breathe in, the pressure inside of the gases is greater compared to out, so it forces it out. On the left-hand side, we see the muscles of inhalation, and on the right-hand side, we see the muscles of exhalation. So the main muscles of inhalation, we have these, we'll call this one here our primary muscle, the diaphragm. That is primary. So when the diaphragm goes down, it's going to pull air inward. We also have external intercostals, the scalene sisters, the scalenus, anticus, medius, and posterior, and the SCM, the sternocleidomastoid. Those are muscles of inhalation. Muscles of exhalation, a lot more of those. So we're going to have the internal abdominal oblique, external abdominal oblique, rectus abdominis, transverse abdominis. It's really all of the abdominal muscles are part of exhalation. The internal intercostals, right? If you think of the intercostals, these are the muscles between the ribs. I always think opposites. So the internal intercostals is for exhalation, but the external intercostal is for inhalation. So the X's and N's are kind of opposite of the ribs. Internal intercostals for exhalation, external intercostals for inhalation. Okay, so for exhalation, it's the internal intercostals and really all of the abdominal obliques, the internal oblique, external oblique, rectus abdominis, and transverse abdominis. The diaphragm is involved in exhalation, but not through active contraction. It's really through relaxation. When the diaphragm relaxes and it pushes up, it helps to force the air out. Some of the breathing patterns, eupnea, this is just normal respiration. Apnea means without, like if someone has sleep apnea, the breathing actually stops for periods of time. Dyspnea is difficulty in breathing. And tachypnea, this is fast breathing rate, like if someone's panicking or they're in pain. Costal breathing is lunged breathing compared to diaphragmatic breathing, which is normal. And these are modified breathing movements, right? Everything from coughing, sneezing, sighing, yawning, sobbing, crying, laughing, hiccuping. These are all modified breathing movements. So you can review those. It's just kind of interesting to look at those different patterns. When we come back, we'll talk about control of respiration, whether it's chemoreceptors or brain and neurological controllers.